Okay, so good evening, everyone from India. I'd like to introduce our today's speaker, Dr. Angelo. He's basically an Italian oral surgeon. He graduated from Aquila University and he specialized in oral surgery in Rome, Sapienza University. He focuses on surgical treatment of impacted teeth using piezoelectric device and atrophic jaw rehabilitation using a reduced number of implants. He do many courses and lectures around the world about those topics. He worked in his clinic, the Clinica Cardielli, in the south of Italy with his brother and father, and also in Milan at San Raffaele Hospital as scientific advisor, and he is adjunct professor at Vita Salute University in Milan. So I highly welcome you, sir, for this session, and I hope that every participant will be, sitting relaxed and will be enjoying this session. So the stage is all yours, sir.
Good morning and good morning everyone, and thank you for your kind introduction. And I'd like to thank Dr. Chiano Shah for having me today in this outstanding event. Today I will speak about piezosurgery treatment of impacted teeth. My best topic, a new minimal invasive approach to treat this type of extraction, as you will see later during my lecture. So, I'd like to start with this emblematic picture. In fact, as you can see, in one day I removed more than 15 wisdom teeth with minimal invasive approach, following always the right protocol, the standard protocol, and using the piezoelectric device to reduce the invasivity for our patient and to obtain a good protocol in this type of surgery. And I'm very glad to be part of the International Extraction Academy of California. And thanks for that again, Dr. Chiano Shah. So the eruption of the permanent included element represent a complex series of genetically controlled events. So during this period, it's possible to have some problems to cause the alteration of the eruption of the dental elements in our arches. So it's possible to have the inclusion of dental elements. And as you can see from this image, the incidence of the included teeth is about 20% in developed population, especially with the predilection for women, as you can see. And absolutely the most frequently impacted teeth are the lower third molar, followed by the upper third molars, followed by the upper canine, the lower canine, and the other dental element, as you can see. So it's possible to have different factors that can cause the inclusion of the included dental elements. As you can see, local factors and systemic factors. Local factors, for example, the extraction of the deciduous teeth, decay on the deciduous teeth. So we have no arched space in the mandible or in the maxilla, ankylosis and alteration of the follicle, and also malposition of dental germ during the development of the future dental elements. We have also systematic factors, as you can see, systemic disease like osteoporosis, like hypothyroidism, like dysplasia cleidochronica, genetically disease. As you can see in this particular case, a young patient, 17 years old, as you can see, we have an alteration of the intraoral situation. We have persistence of the deciduous teeth, hyperdontia, some lesion in the mandible and in the maxilla. This is the dysplasia cleidochronica, as you can see on the right by CBCT reconstruction. And as you can see, it's possible to see an alteration of the clinical intraoral situation. So it's possible to have also systemic disease that can cause the inclusion of the dental elements. And this is the resume about the incidence of the inclusion of the dental elements. And in Absolutely, the most frequent included teeth are are the third molars, lower and upper. So it's very important in this subject to have a good knowledge about the anatomy and about the radiological anatomy. Is very, very important. As you can see in this case, we have a lower third molar in vertical position, and it's very important to see the shape of the roots of this dental element to do a correct surgical approach. In fact, as you can see after tooth extraction, it's possible to see a particular shape of these roots. So it's very important to see with high attention the X-ray pre-op and if is necessary also the CBCT reconstruction. I use always the CBCT reconstruction only if is necessary. If we have close contact between, in case of the lower teeth molar, between the roots and the alveolar nerve, I use always the CBCT reconstruction, not because I will change my surgical approach, but is very important also for medical legal point of view. And as you can see, a particular shape after the cut of the roots in this particular case. Because the anatomy of the third molars upper wall is more variable. As you can see, for example, it's possible to have different shape of roots in the upper molars, as you can see, in the lower molars. And as you can see in this particular case about upper molars, very extreme shape, very particular shape of these roots. So it's very important to know that before our approach. And also using the piezoelectric device, it's possible to have a good approach to avoid the fracture of the bone around the molar and especially avoid the fracture of the roots, especially in the upper side where the visibility is not good frequently. So it's very important the knowledge of the anatomy and the knowledge of the anatomical radiological view. Those are the steps about the surgical approach of impacted teeth. First step, anesthesia is very important to reduce the pain, to reduce the anxiety, to reduce to increase the compliance by our patient. Second step, the flap is very important to choose a correct flaps design. And as you will see later, I use always one type of flap, triangular flap. Another step, bone resection, ostectomy, and after, if is necessary, also the odontotomy, to cut the crown and to cut the roots according to the X-ray pre-op, according to the clinical situation before our surgery. And the last phase is most important. The suture is very important to obtain a good primal closure of our flap, to avoid the infection and to avoid the invagination of the soft tissue in the residual cavity. About the anesthesia of the lower third molar, I use the block of the alveolar nerve using mepivacaine with adrenaline and mepivacaine without adrenaline. I prefer to use the mepivacaine instead of the articaine because in my experience and in my practice, I note that the use of the articaine can cause more ischemia around the soft tissue and more pain during the injection. So in my practice, I prefer to use the mepivacaine without adrenaline on the speak spine with the direct approach, and in the second step, mepivacaine with adrenaline on the buccal nerve to reduce the pain around the soft tissue and to do a correct ischemia and to obtain a good surgical view to reduce also the bleeding. So, and this is a particular protocol to reduce the risk of the allergy in particular patient. This is the dosage in the pediatric patient and in adult patient, as you can see, using the cortisone, using the antihistaminic, for example, to reduce the risk of the eventually allergy. And this is a publication about the the use of the articaine and the lidocaine in the treatment of the lower third molar. And as you can see, there aren't a uh, uh, there aren't a very important difference between the use of the articaine and the respect to the use of the mepivacaine. But in my practice, I prefer to use the mepivacaine. And this is the our surgical view before the anesthesia. We have on the cheek the facial artery, the speak spine on the interior board of the ramus of the mandible, the buccal nerve, and the lingual nerve. And it's very important during the flaps design to have a correct approach to avoid the injury of the lingual nerve, as you will see later. This is the schematization of the interior border of the mandible, the speak spine, and in this side, I do the injection with direct technique. This is the schematization about the indirect technique, for example, using a long sides of needle, as you can see from this image, indirect technique with the long sides of needle around the spike of spine, as you can see. Different barrel with different color, red color, mepivacaine with adrenaline, without adrenaline, and yellow barrel with articaine. As you can see, two different type of needle, medium sides and long sides. In my practice, I use always medium sides and I use the direct technique, as you can see on the right side, using the mepivacaine without adrenaline in the corner of the mouth in the opposite side to inject the mepivacaine on the emergence of the speak spine. As you can see, this is direct technique. This is instead indirect technique with different approach. In my practice, I repeat, I use always direct technique. After the block of the alveolar nerve, it's necessary to do also the anesthesia around the soft tissue on the buccal nerve, as you can see. And in this time, I use mepivacaine with adrenaline to reduce also the bleeding during our surgery. It's very, very important. For example, in the maxilla, I use the mepivacaine with the adrenaline with the medium sides of the needle in case of the palate approach. On the top of emergence of the palatal nerve or the nasopalatal canal. Another types of the anesthesia, as you can see in the vestibular fornix, for example, during the implant prosthetic rehabilitation. In some cases, it's possible to use also the extraoral anesthesia, as you can see on the top of the infraorbitary nerve, as you can see in these sites, and the perilesion injection, for example, during the removal of the fibroma on the lower lips, as you can see from this picture. But I think it's very important to use in this surgery a conscious sedation, as you can see from this video, to reduce the anxiety of our patient, to increase the compliance, to reduce the bleeding during our surgery, to achieve a good surgical view is very, very important, this aspect. And also it's possible to reduce also the blood pressure and to obtain a good management of our surgery. Also, I use a particular protocol in this surgery to reduce the post-op edema and swelling. I inject before the surgery 4 milligrams of cortisone and 4 milligrams immediately after my surgery to reduce the edema, to reduce the swelling, and to reduce the pain. So it's very important to use the conscious sedation, especially in the pediatric patient, to increase the compliance by our patient. As you can see in this video, it's a very simple and easy approach. After to check the vessel, it's possible to inject the benzodiazepine to reduce the anxiety of our patient. As you can see, it's very, very important, this approach. And we have a different device to check the heart activity, life monitor, to check the blood pressure, to check the saturation, and this is the benzodiazepine to reduce the anxiety by our patient. And this is the another device to check the saturation and the heart activity. It's very important in this surgery to have a dedicated instrument, and for this reason, I made absolutely the first kit dedicated for this particular surgery, made with the German company Instrument. So we have different instruments, as you can see, the syringe, the scalpel with the blade, 15C number of blade for the lower to the molar, for the upper blade number 12, and on the right it's possible to see the needle holder for the suture. The exact use of the instruments, the retractors for the tongue, the retractors for the cheek, and to hold the flap. As you can see, I use always two retractors in the vestibular side, the anterior side, and the posterior side to protect the vessel in the cheek and to hold the flap during surgical approach. The periosteel to reflect the flap after incision. Different periosteel, as you can see, mouth, the Pritchard, two different Hudson, surgical Hudson. The hemostatic clamps is very important during the surgery. Two different type of retractors for the lower tilt molar and for the upper molar, and the retractor for the tongue to protect the lingual side, especially during the odontotomy using a traditional drills. And this is bite block to open the mouth during the surgery, especially in the patient with the low compliance. This is surgical phases about correct use of the instruments. The retractor for the tongue, two retractors on the vestibular side to hold the flap. The same approach in different clinical cases. It's very important also to protect the lingual flap using the periosteel by the dental assistants. Two different types of the instruments for the suction. The traditional sites, as you can see, and a small sites. I use this device, for example, when I removed the roots in the very small cavity to obtain a good view using a very small sites, as you can see. And I use also this device, for example, during the guide bone regeneration to avoid the suction of the bone chips during the regeneration. Different type of luxator, straight luxator, different side, angulated luxator, bone clamps. I use the small size bone clamps to remove the soft tissue after the extraction and to obtain a good shape of the residual cavity after the extraction. Different type of the luxator, S shape, straight with the small sides for the apex, as you can see, straight and angulated. And the correct use of the luxator, angulated luxator to remove the distal crown, as you can see, straight luxator and angulated and S-shaped luxator. Different type of the forceps for the lower third molar, for the upper molar with S shape for residual apex, and the bone curette, called curette of Lucas. It's very important to remove the residual parts of the tooth of the bone after the extraction. The correct use of the forceps, for example, with the correct use, correct ergonomical approach, I use always the retractors to obtain a good surgical view and good approach. The scissor, the instruments for to cut the crown, the turbine with dedicated drills, and the straight end piece with different type of drills, shape, bowl shape, as you can see, and particular materials made in ceramic to avoid and to reduce the vibration on the bone during the cut of the crown or during the ostectomy. The correct ergonomical approach during our surgery, the use of the turbine and the drills to protect with the retractors and also in the lingual side, and the use, for example, of the straightened piece to do the ostectomy. But actually, I use for this approach, I use the Piezosurgery set to reduce the invasivity. And for this reason, I made the fist kit dedicated for this particular surgery. It is divided in two sets, which you can find all instruments for this surgery. As you can see, different luxator, different type of the retractors, and a particular forceps, as you can see, as you will see later, to remove the roots during the extraction. The second step is the flaps design approach. It's very important to choose a correct design to avoid the risk, to avoid the injury about the important anatomical structure. For this reason, I use always triangular flap with one horizontal incision between the at the base of the papilla between the fist and the second molar, and one vertical distal vestibular incision to protect the lingual side. As you can see in this image, one horizontal incision between the fist, the papilla of the fist and the second molar, intracircular incision, and one distal vertical incision with vestibular direction. As you can see, to preserve the lingual nerve. This is the right approach, the right flaps design for the treat of the lower third molar. As you can see, after disconnect the flap, it's possible to have a good surgical view and a good approach for the ostectomy, for the odontotomy, and at the end for the extraction of the dental elements. It's possible to use also the same flap in the upper maxilla, as you can see, one horizontal incision and one vertical incision to obtain a good view, for example, during the treatment of the periapical lesion during, for example, the apicectomy. This is the triangular flap. And this is the same approach that I used, the same flap that I use always during the maxillary sinus lift. Triangular flap, also in this case, one horizontal incision and one vertical incision to achieve a good surgical view in our surgical site. And the advantage is a very easy suture at the end of my surgery. And this is the correct design of the triangular flap. As you can see, we have the facial artery and the lingual nerve. So I start with one horizontal incision at the base of the papilla between the first and the second molar, intracircular incision and distal vertical incision to protect the lingual side. As you can see from this drawing, the path of the lingual nerve and the correct design of the triangular flap to reduce the eventually risk. Because in 14% of the cases, as you can see, it's possible to have this path of the lingual nerve, very superficial path. So it's very dangerous to do a lingual incision in this site. But fortunately, in 80–60% of the cases, this is a normal path of the lingual nerve. And this is the lingual nerve in the cadaver dissection. And as you can see, it's possible to see a very good view about the lingual nerve and a very important diameter of the lingual nerve, as you can see. Another cadaver dissection to show the exact path, the exact direction of the lingual nerve in close contact with the lingual bone site, as you can see. So it's very important to use the retractors, to use the periosteel to protect this site during the odontotomy, during the use of the traditional drills. For this reason, by 10 years, I introduced in my practice the use of the piezoelectric device. As you can see, we have a particular different shape of the insert. As you can see, those are the insert that I use always in the extraction of the impacted teeth with the particular shape for the ostectomy. I use always this insert with the particular shape, and the exact use of the insert by the piezosurgery device during the ostectomy, using the same approach, the retractors to hold the flap and the insert to do the ostectomy with the micrometric and minimal invasive cut around the crown, as you will see later by some videos. The correct use, for example, also with the minimal flap, it's possible to do the ostectomy with the close contact between the insert and the tooth to preserve the bone around the crown, to reduce the edema and the swelling, as you can see. And in this video, it's possible to see the correct use of the piezosurgery insert, as you can see. After bone bone dissection, it's possible to do a very micrometric cut around the crown using a particular insert with this shape, and to obtain a very micrometric and conservative cut. So now I have a sufficient space between the bone and the crown to do the odontotomy and after to remove the dental element. But it's very important to reduce the ostectomy, to reduce the edema and the swelling after my surgery. This is our goal. And have a look, for example, this surgical case about the treatment of the lower third molar with the piezoelectric approach. As you can see, this is the initial clinical situation. I use always triangular flap, one horizontal incision, intracircular incision, and distal vestibular incision to preserve the lingual side. Now it's possible to reflect, to disconnect the flap using a correct instruments and using the retractors to hold the flap. Now we have a good surgical view, and it's possible to use the piezosurgery device to do a right and mini-invasive ostectomy around the crown, as you can see. And it's possible to do also a very ostectomy deeper than use the straight end piece with traditional drills. So now we have a good space between the crown and the bone. So according to the X-ray, I cut the roots and the crown with the turbine and the drills. And I use a dedicated luxator to remove, before the distal part of the crown and the roots, use angulated luxator, and after a new clamps with the particular shape is very ergonomical clamps to remove the roots and the crown, as you can see. And this is on my surgical kit, a new particular clamps. And now it's possible to remove the anterior crown and roots using the same clamps. So after the extraction, it's necessary to remove the residual part of the bone of the enamel. I wash the cavity with the saline irrigation always, as you can see, and I put in the sponge collagen for hemostatic reason and to obtain a good plane to do the suture. So with the 4 single simple notes, it's possible to do a good primary closure of my flap. I never use the suture at the base of the papilla because is the best way for the fluid and to reduce the edema post-op. So minimal invasive approach using the standard protocol. So those are the physical characteristics about the piezoelectric surgery, about the piezoelectric device, using a particular type of the ultrasound, and those are important characteristics, clinical characteristics of the piezosurgery device: micrometric cut with micro vibration, selective cut with hammer reaction, and reduce of the bleeding with cavitation effect is very, very important. Because with micrometric vibration, with micrometric cut, it's possible to have a great precision and a minimal invasive approach. selective cut. It's possible to do the surgery also in the site with high anatomical risk, like sinus membrane, like vessel, like nerve. And using a saline irrigation, it's possible to reduce the bleeding and to obtain a good surgical view during our surgery. With the hammering action, it's possible to clean the surface of the insert by the residual bone to avoid the necrosis of the soft tissue of the bone around our site, our surgery site. Is very important, this physical characteristic. And also the cavitation is very important to reduce the bleeding. And have a look to different approach using traditional straight and piece with traditional drill, and this is the histological outcome. It's possible to see a very big necrosis area in this site. Instead, using the piezosurgery device for the same approach, it's possible to obtain different outcome with a very minimal necrosis area in this site. And this is very important to reduce the invasivity and to obtain a good healing of the soft tissue and the hard tissue. And two different approach. In the lower third molar, using on the left the traditional drills and on the right the piezosurgery device. As you can see, we have a very important bone loss after the osteotomy using the straight and piece. Instead, using the piezosurgery device, it's possible to see that we have a very micrometric cut. This is very important difference between the use of the straight traditional end piece with traditional drills and the use of the piezoelectric device. Only one disadvantage using the piezosurgery device is the surgery time, because the straight end piece can work quickly during the osteotomy than respect to the piezosurgery device. Another case, for example, I will show the surgical procedure in the approach of the lower third molar, the X-ray pre-op. I don't use in this case the CBCT reconstruction because we haven't a contact between the roots and the alveolar nerve, the intraoral situation, the correct flap design, one vertical distal incision and one horizontal incision. This is the triangular flap. The correct use of the retractors of the tongue and to hold the flap to obtain a good surgical view. Same approach. I use it after the disconnection of the flap, the micrometric cut with the piezosurgery approach. Now it's possible to cut the distal part of the crown, and after I remove the distal part of the crown, it's possible to remove with the distal movement the residual dental elements all together with the roots. As you can see, the correct use of the S-shaped luxator to remove the distal part of the crown. Same approach, standard protocol, always the residual cavity after the extraction, the correct use of the retractors. I filled always the cavity with the sponge collagen and only for single simple notes to close the flap without suture in this side. This is correct approach. And as you can see on the right, this is the crown, the dental element after the extraction without the distal part of the crown, because it's necessary in this approach to remove the distal part of the crown before and after to remove the crown and the roots all together according to the X-ray pre-op. And have a look at this particular case about the impacted tooth in the mandible associated with a big lesion, as you can see from the CBCT reconstruction. This is the intraoral situation. In this case, it's necessary to have a good surgical view. So in this case, I use a trapezoidal flap with one vertical incision in anterior side to avoid the emergence of the mental nerve, and the distal incision in the posterior side. As you can see, is very important to choose a correct flap design. So this is a good surgical view. We have the odontoma below the bone and the emergence of the mental nerve. As you can see in this image, above, below the bone, we have the impacted tooth in this site in close contact with the mental nerve, and in this site, the large and big odontoma. This is correct flap to avoid the emergence of the mental nerve. It's very important, the choice of the flaps design, always. So this is best case to use the piezosurgery device to reduce the invasivity in very young patients. Is 15 years old. So I do my incision on the bone, as you can see. To draw a correct shape of the window approach, and this is the shape. Oh, sorry. This is the correct micrometric cut using the piezoelectric device. As you can see, very micrometric and precise cut is very, very important, as you can see. Now it's possible to remove the bone block, as you can see, and below there is the odontoma. So also in this approach, I use the piezosurgery device to cut in different parts the odontoma, as you can see, using the same insert of the piezosurgery device, and I remove each part of the odontoma with the minimal invasive approach, as you can see. This is a complex odontoma, and this is very hard tissue. So it's not possible to remove all together, but is necessary before to cut in different parts, as you can see. After the odontoma removal, as you can see, and now I removed the impacted tooth. This is the crown of the impacted tooth, the roots in close contact of the mental nerve, and using the piezo insert, it's possible to do a micrometric ostectomy around the crown, and after to cut the roots in very high risk surgical site, as you can see, considering the very close contact between the roots and the emergence of the mental nerve. So I removed the crown and I cut the roots, as you can see. Some parts of the odontoma after the extraction. I filled always, also in this case, the cavity with the sponge collagen, as you can see. And I do the suture. This is the X-ray post-op after the removal odontoma and the healing of the soft tissue 2 weeks later, with a good healing and a good quality of the soft tissue. So using the piezosurgery device, it's possible to obtain outstanding outcomes to reduce the invasivity. And there are many studies about the use of the piezosurgery device. This is my publication about the comparison between piezoelectric surgery and the straightened piece in the extraction on the lower third molar. And as you can see, using the piezosurgery device, it's possible to reduce the pain, the edema, the trisma, the swelling. Only the surgery time is only disadvantage using the piezosurgery insert. another my publication about the surgical treatment of the impacted teeth using always the piezosurgic device. So it's possible, as you can see in this resume, it's possible to see the advantage using the piezosurgery device to reduce the trisma, to reduce the pain, to reduce the edema, to preserve the soft tissue around the dental elements. Only one disadvantage is the longer surgery time, as you can see. And I will show the last case about the maxilla approach to remove a lesion in the palatal site. As you can see, I do the anesthesia. This is the CBCT reconstruction to show the lesion in the palatal site. So it's necessary to do a palatal approach in this case. And I choose to use the envelope flap in the palatal site without vertical incision, only one intracircular incision, full thickness flap, obviously. I disconnect the flap and I check the emergence of the nasopalatine canal. I use the suture to hold the flap to obtain a good surgical view during my approach. And I use a particular insert with the diamond shape to obtain a very minimal invasive ostectomy to remove the lesion. As you can see, this is a particular insert with the diamond shape. I check the lesion. I continue to open the bone window, as you can see, and now it's possible to remove using the Lucas curettes the lesion with the minimal invasive approach to preserve the bone, especially in this particular surgical site. So the lesion, I remove the soft tissue, I wash the cavity with the saline irrigation as usual, and I do single simple notes to obtain a good primary closure of our envelope flap. Minimal invasive approach also in this case. So I think the use of the piezosurgery device is most important to have a new approach, to have a new minimal invasive approach also in this particular type of surgery. And we have different type of the tips according to different approach for the ostectomy, for example, the implant site preparation, for the extraction, for the bone expansion, for the maxillary sinus lift. In this surgery, I use always the same tips, as you can see, for the ostectomy, the ball-shaped diamonds to do the ostectomy. I use always this OT7 insert to do the ostectomy around the crown of the lower and upper third molar, as you can see, right and left side of this insert, and a particular insert with the particular shape to recover also the bone, for example, during the post-extraction, to use the recovered bone to fill the cavity with the particular shape. So we have different tips for different surgical approach. And this is the drawing to show the correct use of the insert. As you can see, we have an ankylosis root. As you can see, it's possible to use the insert in close contact between the crown, between the roots and the bone to preserve the bone, to obtain a good space between the dental element and the bone, and after it's possible to remove using the luxator, using the forceps, the residual roots. And for example, it's possible to preserve the bundle bone and to place at the same time immediate post extraction implant. So it's very important also in this approach, especially for example during the implant treatment of the extraction site. And at the end, I'd like to show my new textbook about the surgical treatment of the impacted teeth. Now it just came out in Italy, in Italian version, and it will be available in next month in English and also in US with the preface of the best former professor, Dr. Aaron Garg. And in this textbook, you can find more details about the new minimal invasive approach on the treatment of the impacted teeth using a piezosurgery device. So thank you very much for your kind attention. And if you have some question, I will answer here. Thank you very much again.
Thank you so much, sir. It has been really an informative lecture and quite knowledgeable. Your cases have been quite beautifully presented, and it was actually an amazing lecture for everyone. So by the time, I don't think we don't have much questions to ask. Moreover, I am having quite good questions to ask for. So shall I proceed with the questions? The doubts which I have.
Tell me.
Yeah. So do you opt for preemptive analgesia in cases of piezosurgery?
I use always the conscious sedation and the analgesia conscious sedation, also using the piezosurgery device. In my clinical case, I prefer to use almost always the conscious sedation to reduce also the risks, to reduce the post-operative problems for our patient.
Okay, and what you will opt for if like someone is not carrying conscious sedation machine, you know that it's quite large to keep it up in a clinic. So would you opt for like, what do you prefer would be better, preemptive analgesia or conscious sedation? If being me being a clinician, if I don't carry that conscious sedation machine, so should I opt for preemptive analgesia?
In my private office, I use always there isn't a machine for analgesia. I have the colleague to inject the drugs for the anesthesia. The anesthesiology colleague for this approach.
Okay. And what do you suggest for if I compare piezoelectric surgery with heart tissue lasers? What would be more beneficial for bone, like would not cause more bone necrosis?
Using the piezosurgery?
Like in comparison, if I compare heart tissue lasers, which are used currently with piezoelectric surgery, in comparison, what will you opt for?
Yeah, I think the approach of the use of the laser for that the tissue is different, because it's impossible to obtain with the laser of the hard tissue a correct cut, because I think it's very slow to do a cut around the crown and to do the cut on the bone. So I think, in my experience, I never use the laser for the hard tissue for the extraction of the lower third molar, because I think it's the different approach.
Okay.
I prefer use, for example, the laser for hard tissue for the decontamination in case of the periimplantitis. But I think it's not a good approach to use to do the ostectomy for the approach of the impacted teeth.
Okay, so like the lasers which are used to remove caries basically, or for the crown cutting of the tooth, those lasers can't be used for osteotomy?
I use the erbium laser, for example, for decay in the pediatric patient, for the cosmetic treatment, and also to treat the periimplantitis for the contamination. For example, in case of implantitis, to save the implant, I use the erbium laser, and after I fill the cavity with the bone graft. But I don't use for the ostectomy.
Okay. I've got that point actually. So it has been quite a good lecture for everyone. I must know that like everyone would have enjoyed it as well. So I think we don't have much questions from the audience. So we can go on to the end of the session.
Okay.
So thank you so
So
much. Yes, sir. Yes, sir. Proceed.
thank you very much for your support and for outstanding event. And I'm very glad to be part of this event.
Thank you so much, sir. Thank you so much. So with this,
Bye
we'll
bye.
then move on to the end of the session. Thank you.
Thank you. Bye bye.